Get that right? All righty. Hello, hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is March 2nd of 2025, and it is time for another weekly support group meeting. Oh, it's been a week. It's been a good week. Let me introduce myself. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the world. Been doing this for 31 years and counting, working directly with patients and providing information and education and support. Hello, Anne. Hello, Katie. Nice to see you. Right now, we are simulcasting on Facebook and YouTube. Here, let me move this a little bit. All right. Hi, Katie. Anne says, can I use a topical estrogen without an applicator? Sure. Sure. There's no reason why you can't do that. I mean, it depends upon where you need it. I mean, if your dryness is mostly in your vagina, then you can use your finger, but you might need to deliver it a little bit more deeply. An applicator might do that. So, whatever works for you, works for you. My purpose in doing these meetings is to educate, to inform, to comfort, to inspire, to encourage, to give you a well-deserved slap on the tush if you need it, in a nice way to get you to take action that you've been not wanting to take for a long time. I've realized as I've gotten older that I'm seeing how the way I cope with things that upset me is I often just try to pretend they're not happening. It's not a good thing to do when you need to be proactive. These meetings, usually when I do these meetings, I do like a little 30-minute educational thing and then take your questions. Our meeting will last as long as you want it to last, as long as you have questions. I'm happy to be here. Kathy, thank you. She says, I look pretty today. I appreciate that. I'm very nature inspired, so this is one of my few nature shirts. So you're getting birds today. I know that today is the Academy Awards and people are going to want to watch the Academy Awards, so that's okay. We just do what we normally do. I have a couple of interesting things that I want to talk about, but most importantly, do you see the chips off of my shoulder or the fear off of my shoulders right now? No, it wasn't a chip, it's just fear. Do I look just a little bit happier right now? Because I am. Because you know what? I passed my last heart exam with flying colors. Yes, yes, yes. So, I've been recovering from having a double mastectomy, and then I had a kind of catastrophic reaction to the COVID vax that messed my heart up quite badly. And so I've been going through a number of heart tests for the last couple of months, and I passed all of them. And the last one, which they weren't going to do, that I insisted on, was a stress test. I love getting a stress test. I find it personally challenging. The cardiologist was like, you're enjoying this, aren't you? And I'm like, yes, I am enjoying this. I want to see where I am. Better this week than I did 5 years ago. So, my friends, and I'm now back to walking every day. This is really good for my emotional health because I have not been able to walk consistently for about 2 or 3 months. And so now I've walked every day and I feel great. So anyway, I just wanted to share my news because it's been a rocky 18 months. And my biggest worry now is fixed, that my heart is perfectly fine. Knock on wood. Wow. Fear is challenging. And one of the problems with healthcare is that when you're facing a difficult diagnosis, when you're in pain, when you're afraid, they don't necessarily address the fear. I can remember the first time, because I've inherited my dad's heart, and he lived to 100. So I The odds are, hopefully, I will live that long myself if I can pay for it. That's a whole nother story. But I can remember the first time I had some arrhythmias and things like that, and I was really quite scared. And it happened after I took Elavil for my IC. It changed the rhythm of my heart, and it was quite scary when it was happening. And I can remember I had to wear a this was back 30 years ago. I'd wear a heart monitor for a month, and it was quite scary. And I just remember thinking, don't they see how scared I am? Like when you're facing a tough diagnosis, wouldn't it be nice to have somebody hold your hand, look you in the eyes, and go, "You're going to be okay. I know this is hard. I know this is frustrating, but we see this all the time. We're going to do the best we can to try to understand what's going on with your heart. And when we find that, we're going to treat it. So just rest your soul just a little bit." And I think for whether you've had a cancer diagnosis or an IC diagnosis or a heart attack diagnosis, I think getting a little bit of personal comfort is just so incredibly important to easing your soul, easing our souls. It's And yet every now and then you find a care provider who really gets it. And my cardiologist, who at first I thought was a little standoffish, just said, "Jill, we see this all the time. I'm fully confident we're going to understand this and get you through this." And that's exactly what I really needed to hear. Julie, the answer is no, but I will. Well, let's talk about that right now. Okay, so Julie asked, "Do I believe in embedded infection?" And the answer is no, I don't. And let me explain why. So there has been a very vocal group of people for the last 30 years online suggesting to IC patients coming into groups, y'all have a fastidious embedded infection. We've been dealing with this for years. So the concept of a fastidious infection or an embedded infection, but a fastidious infection in particular, that was promoted by Dr. Paul Fugazzotto, who was a lovely older man who ran a pharmacy in North Dakota. And I met him. I had lunch with him. Nicest guy, giant heart. But he believed that patients had a low grade infection. And he developed and promoted doing a 5-day urine broth culture to see if there was a small amount of bacteria that might grow out of the urine of IC patients. And so back in the 1990s, listen, we all sent urine to Dr. Fuzzy. We called him Dr. Fuzzy. And honestly, he was a lovely man. He was just a sweet, nice guy. Um, um, And yet at that same time, remember, we were running the IC network because the IC network is that old. I was doing live events with the top IC researchers in the world. We did more than 100 of those. Every single one of them I asked, literally every single one of them, including the director of the National Institutes of Health who appeared in my series, "Do you believe in the embedded infection theory?" Every single one of them said no. Every single one of them. One of the flaws in Dr. Fugazzotto's approach is that he sent out um, glass vials that we were supposed to collect urine in, that we collected our urine in and sent back to him by mail, usually priority mail, not overnight mail. We later learned that almost all of us had exactly the same infection, which was Enterococcus and Micrococcus. I had it, my mother had it, my sister had it. We all had it, the same one. And as we were working with patients online, pretty much everybody had Enterococcus. And Enterococcus facilis is a beast of an infection, but it was just the trend was really, really significant, like everybody had it. Well, what we later came to learn is that infections survive autoclaving. So Dr. Fuzzy took his glass vials and sterilized them in a heat sterilizer, an autoclave. What he didn't know is that these infections and these biofilms survive autoclaving. So he was sending out vials that already had the infection in it. And so and again, I don't remember who I was talking with, but again, a lot of the top IC researchers were like, no, there's just a flaw here. And the perception was, if you can take if a live urine sample at a doctor's office and not put it in a glass vial and not send it through the mail for a period of time, and if you can replicate those results where you're peeing in a cup, it goes to the lab immediately, they test it immediately. If that finds it, it's another story. But the thing is that wasn't finding it for us. I know, yeah, Julie. So hold tight. So anyway, it just kind of ebbed and flowed and ebbed and flowed. There were people who believed in it, people who didn't. There were people online who said, you all need to be on antibiotics for a long term. And then there are others who are saying, prove it, give us data. Dr. James Malone Lee, who has since passed away, who was in the United Kingdom, absolutely believed in the concept of embedded infections. And he has a very vocal group of patients online who do too. And they used to come into these meetings and they would be somewhat disruptive. I talked with Dr. Malone Lee several times before he passed away. The pivotal moment to tell you why that approach is, in my opinion, wrong, is when they started studying the urinary biome in IC patients. So we now have next generation testing, which will take a sample of urine and look and identify everything living in that urine based upon the DNA that they find. So basically, you send them a urine sample and they blend it up, break everything up. So now we have free floating pieces of DNA. They grab the DNA and they match the DNA to big giant databases to identify what's actually living in there. So next generation DNA urine testing has now allowed us, number one, to find weird random infections. As an example, I was going to talk about a patient I just worked with who had bladder tuberculosis. 10 million people a year get tuberculosis around the world. And normally when you think of tuberculosis, you think of lungs. Well, guess what? The tuberculosis, I think in like 30% of patients, actually becomes systemic. It spreads through the bloodstream, gets to the kidneys. He had kidney tuberculosis and he had bladder tuberculosis. So, and that's amazing. And we're going to treat that. Once they identified the tuberculosis, since tuberculosis is highly, highly contagious, they identified it and they treated it with the correct antibiotic. So, next generation DNA urine testing is, in my opinion, the absolute way to prove it or not. So, like, there are some patients out there who say, hey, man, I'm not taking anything but antibiotics. I have an infection. You can't tell me anything else. I refuse all of your other treatments. All I want is antibiotics. And they've already been on antibiotics for years, and they're not better. And the embedded infection people pretty much say you need to be on antibiotics for a long period of time. And yet there are people out there who have done that, who have not gotten better. And I had one patient call me last year who just said flat out, I refuse. I'm not doing any IC therapies. All I want is antibiotics. And her doctor said, no, you've had plenty. You don't understand the damage they're doing. I'm not giving you any more antibiotics when I can't find an infection in you. And she called me in despair, like, what do? I want antibiotics. And my answer back to her was, prove it. If you think you have infection, prove it. Have a next generation DNA urine test. If the urine test comes back positive, then you're good. You can present that data to your doctor and say, hey, look, next generation testing absolutely found infection. But the far more important point that I made to her, hold that thought, Katie. The far more important point that I made to her is, listen, if your next generation DNA urine test comes back negative, then you have to walk away from this theory that you have an infection. Okay, because if it doesn't find anything, then you don't have infection. Now, Here's the kicker that I think should give you great pause in doing long-term antibiotics. So remember now for like the last 10 years, they've been doing what we call urinary biome tests with next generation DNA urine testing to look at the urine of IC patients. And they're looking for, they're looking for the smoking gun, right? I mean, they're looking for anything and everything that might account for these symptoms. And all of the next generation testing and all of the biome testing in the typical IC patient population showed completely normal bacteria. However, it was less diverse and there was more lactobacillus. And there's like five or six studies who made that finding that the typical IC patient, normal biome, less diverse, more lactobacillus. And so a couple years ago, this fabulous biome researcher named Ann Ackerman at UCLA said, "Oh, you know what? Let me see if I can make heads or tails of this." And so she did her own study in her lab at UCLA with, I don't know, 70 or 80 patients. And she too, at first, found a normal biome, less diversity, more lactobacillus. But she was the first to separate her data based upon age. And then she separated her data based upon phenotype. And that was the breakthrough. Because when you look at the biome of somebody with pelvic floor driven symptoms, as compared to somebody with widespread pain, as compared to somebody with bladder wall driven symptoms, you see huge differences. Patients who are primarily pelvic floor driven, completely normal biome. Normal. Nothing wrong. Patients with the widespread pain or pain outside of the bladder, they tended to be dominant in E. coli. And I think that would explain bacteria. You know what? Let me take that back. Patients with pain outside of the bladder, not the widespread pain group. Patients with pain outside of the bladder, but not in the bladder, they were dominant in E. coli. So that's fascinating. And that helps us understand bacterial vaginosis, maybe. And I mean, we're learning a lot about E. coli infections, but those were not the bladder wall driven patients. The bladder wall driven patients had a remarkable finding. They had a bacteria called Lactobacillus iners. Now, lactobacillus is good, right? Not this one. So Lactobacillus iners was only discovered like 6 or 7 years ago. It's a brand new lactobacillus. And the way they found it is they added blood, of all things, blood, to a culture medium. And when they did that, this brand new lactobacillus that they'd never seen before grew, called Lactobacillus iners, INERS. Now, the problem with this lactobacillus is that it is not a beneficial bacteria. It is, in fact, a pathogenic bacteria. Lactobacillus iners behaves more like other bad infections. So, number one, it doesn't control fungal infections like most lactobacillus does. And number two, it actually damages cells. So, smoking gun, there's a little smoking gun for the bladder wall patient, not for the pelvic floor, but for the bladder wall patient, for some bladder wall patients. So the question then becomes, well, how does the biome get dominated by Lactobacillus iners? So we have data. I mean, they've found it in bacterial vaginosis. They found it in a number of other conditions. Patients who are dominant in Lactobacillus iners have poor outcomes as compared to patients who are dominant in Lactobacillus crispatus. Crispatus is a really good beneficial bacteria. If you are taking probiotics, look at the probiotic and see if it has Lactobacillus crispatus, like a crispy. Okay. Um, so Lactobacillus inners, we now know, is a sign that we have a very badly disrupted biome. Well, it turns out that the reason why it becomes dominant is because of antibiotic use. That when you take an antibiotic and you destroy that biome, good bacteria and bad bacteria, one of the very first bacteria to start growing back quickly and rapidly, and it begins to dominate the biome, is a pathogenic Lactobacillus inners. So Lactobacillus inners is in fact an opportunistic infection that occurs after antibiotic use. Now, if there was ever a group of patients who are completely overexposed to antibiotics, it's us. Because what's the problem here? You've got the symptoms of a UTI, frequency, urgency, pressure, pain. You go to the doctor, or back in my day, you called the doctor, hey, I got an infection. Can I get some antibiotics? They just prescribed them over the phone. They didn't even do cultures back then. Now they're supposed to do cultures or something to try to validate and prove that there's an infection. But we have all, in all likelihood, been massively over-treated with antibiotics. And that kind of gets to the story that I'm going to talk about today, and that is so many of us assume we have infection, or so many of us assume we have a bladder disease, when in fact, for most of us, it's really a neuromuscular issue. And that we took those antibiotics for something that felt like an infection, but it really wasn't an infection. And we were harmed because of that. And the same applies to patients who took Elmeron. Pentosan polysulfate. We now know that that's linked to eye disease. And now that we're doing phenotyping, and we understand these distinct groups, we now realize that most patients are neuromuscular, and that a bladder coating makes absolutely no sense. And some of you have been doing bladder coatings for decades and not gotten better. So getting back to my question, do I think IC is embedded? Absolutely not. I do not. What our research shows us is the vast majority of patients, 80 to 85% of patients, are neuromuscular in origin. Do I think that there's a small population of patients who might have infection? Yes. The question is, what kind of infection? Like the gentleman I worked with who had tuberculosis in his bladder, that's a possibility. And we also now have found fungal infections and viral infections in the bladder. We now know from our own National Institutes of Health IC research that fungal infections are known for causing bladder pain, and the more fungus you have, the more pain you have. So like if you flare after eating sugar or carbs, you've got a fungal infection. No doubt about it. If you have a Hunner's lesion, there is a chance that you have a viral infection, specifically the Epstein-Barr virus or the polyoma virus. Those are possible causes for lesions. So I think anybody who says every patient has an infection is ridiculous. It's ridiculous. And that shows that they're not reading the latest research, and they're not reading our national guideline. But if you think you have an infection, I would say, okay, put your money where your mouth is and prove it. Do an next-gen test. Do a next-gen test. And one of the points that I've made constantly is you deserve more than a guess. You need facts. And the ultimate flaw in IC care for the last 30, 40 years has been doctors guessing about what's wrong with you, or assuming you have a bladder disease, or assuming this or assuming that. Today, we want to make our medical decisions based on facts. So, like, number one, if you're peeing blood, for God's sake, you need to let somebody look in your bladder. That's important. Don't force them to guess. Hey, Jill, I don't know why you're bleeding in your bladder. It might be this, it might be that. Let's try a little bit of this, a little bit of that. My answer is no. I don't want you to do that. I want you to look at my bladder and see what's bleeding first, and then we'll talk. Right? If you think that muscles might be part of the problem, then for God's sake, go get a pelvic floor assessment. If that comes back positive, yep, your muscles are locked down tight. Great data, great information. You need to go to PT. If that comes back normal, then we're going to move beyond and we're not going to do PT. But you have to stop guessing. We need facts. So I wish that I could say that we have widespread acceptance of the lactobacillus inners, but this research is new. They've only been talking about it for 2 years in the IC courses that are taught to urologists at the American Urology Association. Ann Ackerman is one of the featured lecturers now, and she ends the event, and she ended the event last year with a urgent plea to urologists to stop prescribing antibiotics randomly or for flares, that there are unforeseen long-term consequences to antibiotic use. Now, the other issue that we have with antibiotics is, so when we think about long-term antibiotic use, we're always thinking about damaging the biome. It allows fungus to grow and allows bad bacteria to grow, exactly like I said, with lactobacillus inners or with C. diff. Our underlying assumption was that that's how antibiotics are harmful. But we now have a new study that shows that antibiotics interfere with the mucosal cells in the bowel, and it damages the protective layer structurally of the bowel. And that was just kind of shocking. Because if it's doing that to the bowel, is it probably also doing that or possibly also doing that here to the bladder? The answer is yeah, absolutely. Yes, Julie, it's microgen. Sherry says, I was given many antibiotics when I had rheumatic fever when I was 8 years old. I'm wondering if that's why my bladder and pelvic floor is so messed up. I don't know why that would mess up your pelvic floor, except if you were under a lot of stress, fight or flight, anxiety. That's always possible. When you're a child and you're in pain and they're giving you lots of treatments and they don't necessarily explain what the treatments are doing, then that child gets scared. And you can be in fear for a long time. And that also creates a lot of problems with the body and with the central nervous system. Sandy says here, is it common to have an IC and IBS constipation flare with type flare? Yes, that's very common. Very, very common. I've had, my pelvic flare is finally easing up. I was in a pelvic floor flare for about 10 days. And it finally calmed down today and yesterday. I'm no longer having all the vaginal symptoms that I was having and the vulvar symptoms that I was having with tight pelvic floor muscles. Very interesting. Okay. So hold on a sec. Julie says, if the microgen test is positive, yes, it is infection. And they will identify the infection. They will identify antibiotic resistance genes, and they will identify the correct treatment for that specific infection. Kako says, have they come up with a way to treat the overgrowth of lactobacillus or rebalance it with probiotics help? As far as I know, they have not. I haven't looked at the research in a couple of months. But rebalancing the biome is critical. And so doing probiotics, and I don't support doing the same probiotic over and over and over again all year long, because You're just reseeding your bowel with a very, a limited group of beneficial bacteria. I like the idea of mixing it up a little bit, doing one probiotic for a couple months and then switching to another one. I would just say is look for a probiotic that contains Lactobacillus crispatus. I think that's considered the best long-term. It's associated with the best long-term outcome for patients. Jenny says burning urethra most of the time when bad cramps and urgency. So Jenny, when we see a burning urethra, we're really going to be looking first to estrogen atrophy. The urethra is kind of the canary in the coal mine when it comes to estrogen loss. What happens is that skin starts to dry out. The mucosal layer on the vulva and the vagina in the urethra and the bladder start to thin. And it happened to me when I was 51 or 52. It felt like there was a drop of urine stuck in my urethra that would not come out, and it just burned and burned and burned. And I finally threw myself on the mercy of my urologist, who took one look and he goes, "Jill," and I'm like, "What?" Imagine, I'm laying in the stirrups and he's down between my legs looking at me. And I loved my urologist. He's since retired. Lovely, lovely man. And he's like looking down there and he looks up at me and I'm looking at him through my knees going, "What? What did I do? What did I do?" And he goes, "Didn't you use the estrogen cream I prescribed for you last year?" And I very meekly went, "No." And he said, "Why?" And I said, "Because in my brain, I'm 25 years old and I can't possibly have an age-related issue." Which is true. Which is exactly how I felt. And I still feel it. And I'm 10 years older. And he explained the whole canary in the coal mine thing, and he re-prescribed the estrogen, and I used it, and it took about 10 days for it to go away. And yes, if microgen comes back positive, then it is infection, and they will absolutely identify the infection. So on this topic, what I wanted to talk very briefly about here was a patient that I worked with, and I'm going to call her Carol. So Carol, and actually wrote a blog on it. Okay. So Carol was diagnosed with IC 25 years ago. She was told that she had an incurable bladder disease. And what caused her to call me was because she was flaring very badly again. So it was fascinating talking with her because she did everything. She did Elmeron, she did antidepressants, she did antihistamines, she did neuromodulation, she did Botox, she did bladder installation, she did everything. She had been doing everything for 20 years. And her go-to for her flares were basically bladder installation. And yet, despite doing all of these treatments, she didn't get better. And she was still flaring badly, frequently, and had been flaring for 20 years off and on. And again, she was operating on the assumption that she had an incurable bladder disease. So I talked to her about, what do our guidelines say? If you're not responding to therapy, if you're getting worse rather than better, stop what you're doing, take a step back, revisit the diagnosis, which she'd never done, and her doctors had never done. And then we went through the phenotypes, and this is where it got really interesting, because her cystoscopy showed a completely normal bladder wall. She could eat anything. Food did not trigger pain. What triggered pain was sex, driving, and sitting. Agonizing pain. She had severe constipation. And what's that critical question we asked to differentiate between bladder and pelvic floor? Can you pee on command, or do you hesitate? 5, 10, 15, 20 seconds before you can relax enough to release urine. She hadn't been able to pee normally in years. She was sitting waiting. Does that sound like a bladder disease to you, my friend? She can eat anything, perfectly normal bladder. Sitting, sex triggered her symptoms. Does that sound like that's coming from the bladder? Of course it's not. That's coming from her pelvic floor. And I asked her, I said, okay, is there any event that you associate with the onset of your symptoms? Yeah, she'd had a very, very bad pelvic injury. I was working with a gentleman like on Thursday or Friday who broke the top part of his hip bone. It's a bad he had a really awkward bad fall. I think it was off of a bicycle. And it broke the top of his hip in multiple pieces. And he was now struggling with urinary symptoms. And he did not understand, just like Carol did not understand, that tight dysfunctional muscles can trigger pain. And again, for Carol, she had never had sex without pain. She thought sex was supposed to be painful. She had been constipated her entire life. She couldn't sit, she couldn't drive without extreme pain. And it's really quite infuriating to me that, we have known about the muscles since 2008. And then 2011, the new guidelines came out, which showed you're supposed to check the pelvic floor muscles at the first appointment. And if you find tight muscles, you're supposed to send them to pelvic floor therapy immediately. So come on, 14 years have passed and she's never had a pelvic floor assessment? Heartbreaking. So she's not alone because we hear this story all the time, especially from patients who were diagnosed 10, 15, 20, 30 years ago. And one of my missions is to find you and to help you find other treatments which might be successful. So if you've been investing in bladder treatments for years and you're still flaring, are the bladder treatments helping? Are the bladder treatments fixing the underlying problem so that you won't flare? Clearly not, because bladder treatments don't do that. Bladder treatments can help reduce the symptoms and calm the symptoms, but they don't fix anything. They calm nerves down. They can get you out of pain to give you a kind of a foundation for your whole body to calm down. Pelvic floor physical therapy has the potential of healing patients completely if you're in the pelvic floor driven group. So today, urologists across the United States are slowly recognizing that traditional IC treatments are often ineffective, that many patients do not have signs of bladder disease, and that remarkably tight dysfunctional muscles require treatment. There's also a significant group of patients who have multiple pain conditions such as IBS and vulvodynia, migraines, and fibro that we now believe relates to a past injury or trauma. Simply put, almost every past study. Now here's the shocker. This is why I need you to understand this. Every treatment study funded by the National Institutes of Health and most pharmaceutical companies, we're talking hundreds of millions of dollars. Pretty much every study failed, with except one. The only study that showed significant success in the 60 to 70% range was the pelvic floor physical therapy. And when that study came out, the entire IC world went, uh-oh. How would physical therapy help an incurable bladder disease? Maybe it's not an incurable bladder disease. Maybe it's a problem with muscle. So the other thing that happened is we now have a fabulous new article, interstitial cystitis, matching therapies to the patient, written by Jennifer and Robert Moldwin. Now, these are literally one of the best IC clinics in the world is at their clinic. Rob Moldwin was the first to write a book on IC called The IC Survival Guide 25 years ago. Now, it's old and outdated, so don't go buy it now because we've learned a lot about IC since then. But this article is free and on our website. And I wanted to read a couple of sections about this. Now, it is very academic. It is for doctors. Clinicians who routinely treat IC patients know that a one-size-fits-all approach simply does not work. This population is phenotypically heterogeneous, means different, likely accounting for the clinical frustration of patients and practitioners and the failures of numerous therapeutic trials. Much of the heterogeneity or differences we see among patients stems from the broad definitions that have evolved internationally, since IC was originally described as a disease. The definition has evolved. I'm just trying to go through this. So one of the points they say here is failure of these clinical trials and similar trials prompted a relook at the study design by experts in the field who concluded that a, quote, everyone is welcome protocol was likely the reason for clinical trial failure. So anyway, and here, they also say, so they're talking about 4 phenotypes, but they call the phenotypes a work in progress, that they remain broad brushstrokes, but they could be leaving out other important factors or other phenotypes. So, and they say, for example, approximately 80% of patients with IC will have pelvic floor dysfunction. Okay. So our entire world is better. Our entire world has changed because we don't want to condemn you to investing thousands of dollars, much less precious years of your life doing treatments that do not have a chance of helping you. Today, doctors are supposed to phenotype first to figure out what group you're in. And then your treatment is supposed to be individualized based upon the group you're in. So if you've got Hunner's lesions, you're going to do Hunner's lesion therapies. If you've got pelvic floor dysfunction, you're going to be doing physical therapy. If you've got widespread pain, you're going to be doing treatments that target the central nervous system. If you've got non-Hunner's lesions, bladder wall driven, then we're going to look at other things that we can do there, like the Mirbatrix and things like that control frequency urgency. So anyway, over on the IC Network website, the first blog up there, in the latest research one, is this article I wrote about Carol, and you can download your own copy of that article. The other thing that I said in this article is that I think that there are 5 more phenotypes. They tend to lump people together, and I think fundamentally that's a flaw. I think we have to break it out even more. And so is there a chronic UTI group? Absolutely. I do believe that there's a chronic UTI group. And in that chronic, but I think it's a very, very small number of patients, maybe 2%, 2 or 3%. But in this chronic UTI, we need to look for fungal infections. We need to look for bacterial infections. We need to look to lactobacillus, because that I have a lot more credibility associated with lactobacillus inners than I do any fastidious or embedded infection theory. Another phenotype is ligament laxity. The uterosacral ligament, if it's damaged, if it's weakened, if it's stretched out, that's going to cause problems, and that can even lead to the development of Hunner's lesions. One of the groups that I think is really, really interesting that I don't understand are the patients who go into total remission. when they get pregnant. So I had a good friend, a good IC friend from years and years ago who's in my original IC support group with terrible symptoms. I mean, and she was young. She was in her 20s and her life was completely dysfunctional. She could not do anything because she was in so much pain. And she met a lovely man and they ended up getting pregnant. And you know what happened? Symptom free. It completely turned off all of her IC symptoms. It was shocking. And for her entire pregnancy, for the first time in any time that she could remember, she had no urinary symptoms at all. And then once she weaned off of breastfeeding, her symptoms slowly came back. And so she decided that getting pregnant was good. So she ended up having multiple babies. I don't understand that phenotype. I think that is some sort of hormone dysregulation problem. I just don't understand that group at all. Um, I think there is certainly a group of patients who are driven by allergies, and Dr. Curtis Nickel talked about that in his 9 phenotypes. So if you're somebody who flares during allergy season, or if you have asthma, a brand new study just came out that linked asthma genetically with IC in some patients, which was fascinating. So if you flare during allergy season, then your treatment is probably going to be an antihistamine. And then the other group that I find fascinating is the autoimmune group. There is maybe I think the last time I looked at the statistics, like 2 to 3% of IC patients had lupus or Sjogren's. They had an autoimmune, other autoimmune conditions. And I think that that also is a very distinct phenotype that we need more information about. So, just to summarize, if you're not responding to therapy, if you're getting worse rather than better, our guidelines say stop what you're doing, take a step back, revisit the diagnosis. What could we have missed? Because nobody should be suffering to the great degree that they're suffering. If we find the underlying cause, we can treat the underlying cause. And thankfully, for the great majority of us, it goes back to an old pelvic injury of some type. And if anybody, it's just you just don't get it, and you want to talk about the phenotypes, listen, I'm available, and I do coaching, and I help the phenotype patients every day, literally, except for Saturdays, which is my day off. You're always welcome to call me. I'm happy to take a couple of questions, no charge, not a problem at all. 99% of my work is free. But if you want to spend a lot of time, or we take a lot of time, like I was working with a patient who called on Friday and she said, let's see how long we go and I will pay you for your time if we go long. And we went an hour and it was very nice that she paid. I wouldn't have asked her to pay it, but she volunteered that. I'm just here to help. Guys, I'm just here to help you because I know what it's like to suffer in silence. I've been there. Summer 1993 was the worst, most severe pain I've ever had in my life. All right, let's go back to your questions here. So remember, we're simulcasting. Over here is YouTube. And hold on a sec. Got to fix these cameras a little bit. The YouTube camera is about an inch above the Facebook camera. So, okay. V says, well, hello, V. Nice to see you, hun. My symptoms are not frequency, urgency, just pelvic pain, mainly perceived as bladder, cystoscopy normal, constipation, lower back pain, no burning or pain when the bladder is full or while peeing. Pain is mostly when stressed, driving, and after using the bathroom. The pain feels like tightness. Is that all correlated with pelvic floor? Hell yes, that's correlated with pelvic floor. Absolutely. Have you had a pelvic floor assessment, girl? If you haven't, you need to get there. Again, Cystoscopy normal, bladder wall normal. Guys, don't be confused by that. Recognize that as good information. You have a healthy bladder wall. So clearly your symptoms are being caused by something outside of the bladder. At constipation, again, low back pain, no burning or pain when the bladder is full, 100% pelvic floor. That tells me you have a healthy bladder wall. You started with a pelvic floor therapist a week ago. So what'd they find during your first exam? What'd she find? What did your pelvic floor assessment show? All right, let's come here to Facebook. Now, you guys, listen, be the squeaky wheel. Be the squeaky wheel. If I missed your question, just ask it again because Facebook always feeds these questions to me weirdly. You can ask. Don't be offended if I don't answer it right away. Just ask it again because sometimes I miss like half of the messages on Facebook. I did not just pick my nose. I just want you to know it just itched. Okay. Jenny says, I've been using estradiol cream for a year. You still have a burning urethra. Okay, so Jenny, I have an article on our website, The 7 Causes of Urethral Pain. One of the things, so a couple of things that we would be looking for. Number one, your pelvic floor. Because around your urethra are your levator ani muscles. And if your muscles are tight, that's going to cause a burning sensation. So that's one thing to look for. The second thing we're going to look for is an infection of your periurethral gland, which is a gland halfway up the urethra. It is the female prostate gland. It's a homologue to the male prostate, which means it looks the same. It has the same cell structure. So we women, hey, guess what? We have a prostate too. They just give it a different name. It's called the periurethral gland. And like the male prostate, it gets infected. And like the male prostate, the drainage ducts are so tiny that they get blocked. And so you end up with what is basically a deep pimple. And you can figure out if you have this by just simply washing your hands really well, putting a glove on if you have it, putting your finger about an inch into your vagina and touching the front. And if you feel any painful little lumps, like the size of a green pea, then you have an infected periurethral gland and they need to drain it. You could be having a reaction to soap, detergent, mini pads. You could have some pudendal neuralgia going on. So there are lots of different things that could trigger urethral pain. Debbie says, 25 years, I think my pelvic floor is broken. The blessing here is that muscles respond beautifully to therapy, provided they're not really stretched out. The challenge here is for when muscles get weaker, they can start to prolapse, and that stretches things. And if you catch the prolapse early, physical therapy can nip it in the bud. But if you wait until it gets really bad, your muscle, it's going to be much harder to rehabilitate. Guys, I did, hold on a sec. So V says, tightness in the back muscles, the one in the back of the rectum, I was to relax. So the pain subsided during evaluation, but she taught you how to find the muscles during a flare. And I found out which. Good girl. This is great. Good job. Good job. Good on you. That's where you need to spend your money. It's working on muscles now. Aaron says, what treatments target the central nervous system? Things that calm nerves down. So from a over-the-counter supplement standpoint, it's going to be PEA, Peora, palmitoyl ethanolamide, acts directly to calm nerves down. And the IC study in 2019 showed that 87% of patients responded well to Peora. You can see it in the back right there, those blue bottles. That was, I took the IC study to natural approach nutrition and said, can you make us something like the PEA from Europe that was used in that study? And they did. And that's Piora. And that's become a mainstay now for patients who struggle with widespread pain, myself included. That's what I take because I have a healthy bladder. I don't need to take bladder therapy. It's my muscles and my nerves that are problems. So I'm very focused on treating muscles and treating nerves. If the over-the-counter supplements don't work, then you could go to medications like gabapentin, Neurontin. You could do a low-dose antidepressant, meds like that. That would help too. Wow, you know what? We have thunderstorms coming in. It's getting dark. Hold on, let me turn on a light. Jenny says, what do I consider to be pelvic floor therapy? That's easy. A finger in your vagina massaging muscles. It's myofascial massage. You can't reach the muscles from the outside. So what the research showed, the big research study compared myofascial massage with generalized massage, and it was the hands on the muscles, working with the muscles that did the best. And so let's look at that for a moment. So here's your pelvis, hip bone, hip bone. So that guy I said that I was working with, he broke off the top of his hip bone right here. Pretty bad injury. Okay. So this is from the front. Here's your pubic bone, hip bones, spine, sacrum. Okay. Now, if we look at it from the back, same thing. Hip bone, or hip bone. It's so hard. It's reversed for me. Hip bone, vertebrae, sacrum. Those holes in the sacrum are where nerves emerge, your pudendal nerve. Tailbone. Okay. Now look at all the muscles that attach to the tailbone. You see that? Look at all those muscles. How do we reach those muscles? These are the muscles that get messed up. I was working with a gentleman who had IC begin fairly suddenly earlier last week, and we now believe that 90 to 95% of men diagnosed with chronic prostatitis and IC that it really is neuromuscular in origin for him. And even though he had urinary symptoms, he couldn't pee on command, and he had pain when he sat down, which of course points towards muscles. And I explained to him, I said, okay, were you an athlete? He goes, yeah, but I don't get it. I don't see why that would matter. And it's like, what was your sport? He goes, baseball. And I was like, oh, okay. How many times did you slide into first base? He went, oh, oh, that makes sense. Because when you're sliding, when you fall like that, you're landing on these muscles. I asked him how many times he thought he'd slid into, he played baseball. He was like semi-pro for 30 years. Hundreds, if not thousands of times. All those repetitive traumas landing on these muscles, it's going to take a toll on these muscles. You're going to start damaging those muscles. So from a physical therapy standpoint, look at what I can reach with a finger. See that? A finger can reach all of these muscles. And so the physical therapist, and so what happens is these muscles normally lay flat at the bottom of the pelvis. But when they get tight, they lift up. They lift up and they kind of stretch across the pelvis, and that's when they start interfering with a lot of things. And so hands-on myofascial massage, you're going for the painful point wherever it is, and you're going to massage that point and try to get that muscle to massage. Try to get that muscle to release and relax. But see how far we can go. And the other thing that's so interesting, I remember one of the first times I think the first time I had a pelvic floor assessment, she was way over here touching my hip bone. She goes, "Oh, that's your hip," and it didn't hurt at all. It's like, "You're touching my hip?" She goes, "Oh yeah, I touch it all the time." I personally have never found physical therapy to be that painful. The act of physical therapy where they were working with muscles. I'm a giggler. I giggle. I don't go ow. I giggle. I'm weird. Anyway, um, I really have never felt great discomfort anytime I was doing internal massage. It was after I put my clothes on and started walking to my car and then sat in my car. That's when I knew I'd worked with these muscles. And yeah, sometimes it did hurt quite a bit. But I knew that was the direction I needed to go. A lot of patients drop out of physical therapy because it hurts. And it's like, no, 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 no. If they're touching a muscle and triggering your pain, that means they're in exactly where the right area where they need to be. You just need to tell them that's a little painful. Can you back off a little bit? And the only time that I experienced that more severe pain was because I'd had a hysterectomy and my everything was very tender down there. Harriet says, could it be that the ligaments relax? Yes, if the ligaments start to stretch, that's a problem too. Sandy says, I do notice when I have constipation, I have to push and push to have a bowel movement. My pelvic floor gets tight and you urge to pee. Constipation causing an urge to pee. Exactly. Like, have you ever, I noticed this for me because, I had IBS in my 20s, pretty bad IBS in my 20s. And there were some times, where I would go out to dinner and I finally learned that it was salads that was triggering me. When I would eat a salad and I'd be on a great date with somebody and I'd have to go home 20 minutes later because I'd have diarrhea. And not just diarrhea, like agonizing cramps for a couple of hours, which was, IBS. And I distinctly remember a couple of times I'd, I couldn't urinate. I'd have to wait 15 to 20 minutes for my muscles to relax enough to allow me to empty my bladder because I was having such strong bowel spasm. In the nature of IBS, we now know that IBS is a related condition to IC. It's about very, very sensitive nerves and nerves getting triggered. There's a wonderful website, helpforibs.com, run by Heather Van Voris. She was so helpful to me. I love her product lines. One of the things she explained to me, I was like, why is it salad? For me, my triggers for IBS are chocolate, lettuce, and oatmeal. Almost every time. It's like, why? Heather explained to me why. And she said the nerves in your bowel are so sensitive that when you eat something that has rough edges, they basically tickle in a bad way the bowel as the food is moving through your system. And back when my IBS was really bad, it was like poison. Wherever that food was in my intestine, it spasmed. And when it finally got to my large intestine, I would feel it here, and then I would feel the spasms going across my belly, and then they went down my left side, and then they ended up at my rectum. And it was like my body was interpreting that food almost as poison. It's weird. Lisa says, you keep losing the feed. I don't know why, honey. Sherry says, do I ask my primary doctor about getting the microgen testing? Do you think it's covered by insurance? It's covered by Medicare. All you can do is ask. Harriet said, is an internal exam to check and stretch pelvic floor massage, cupping, and strengthening the abdominals. Good. Julie said, just to clarify, if tests show bacteria, then it isn't IC. If tests show bacteria, then your diagnosis would be bacterial cystitis or fungal cystitis or viral cystitis. The challenge is for many patients, you have positive tests and then negative tests and then positive tests and negative tests. And that your doctor is going to dump you into the IC group because it's a complex situation. And the question then becomes, why are you prone to getting so many infections? And the answer is probably estrogen atrophy from menopause. So that's IC phenotype 2, bladder wall driven genitourinary syndrome of menopause combined with recurring UTI. So you would fit in the IC group, but your underlying cause is simply menopause with infections. Wendy said, I'm headed to the OBGYN tomorrow to see what he says about my fibroid that is pressing on my bladder. I've been in pain since May. I had Botox and bladder installations, hoping this is 50% of your problems. You know, Wendy, we've got very clear research that has linked fibroids to urinary symptoms, urinary pain. And what that research showed is that when you remove the fibroid and remove that pressure from the bladder, the urinary symptoms go away. So I hope that's the case for you. And for anybody who's wondering why I keep doing this, it's because these are where my incisions are. And they just hurt. I have to release the discomfort, you know? So just bear with me as I rub my chest. V says, can you have pelvic floor dysfunction and still feel the pain like it's located in the bladder? Absolutely. One of the reasons why tight muscles trigger all sorts of problems is that tight muscles don't just squeeze the muscles. They squeeze nerves. If you have a history of sciatica, you've got pelvic floor dysfunction because that's the pelvic floor squeezing the sciatic nerve. But they also squeeze blood supply. They squeeze arteries and veins. And so if your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? Of course not. Because your bladder's being deprived of essential oxygen and nutrition to be healthy. We call this ischemia or ischemia. And that's basically where tissues start to struggle and suffer because they don't have good blood supply. So we've long considered IC basically pelvic ischemia or ischemia from tight muscle. And that's going to cause bladder symptoms. Jenny says, can it be pelvic floor even though I pee on demand without hesitation? It could be. You know, I mean, that's the whole point here is that's why you go have a pelvic floor assessment. Otherwise, you're guessing and you deserve more than a guess. I mean, now that we have this data showing that 80 to 85% of IC patients are driven by muscles and nerves, our guidelines say you're supposed to have your muscles checked at the very first appointment. And so if bladder therapies aren't working and you're struggling to get better, and you haven't had a pelvic floor assessment, that's your first step. You got to get that checked. Let's see what's going on with your pelvic floor. And there can be other things that are going on, like a fibroid tumor pushing on your bladder, or this, or that, or this, or that. But we start with the big things first. Now, is there a chance that you've got something rare? Yeah, you could have a Tarlov cyst that's compromising a nerve. You could have posterior fornix syndrome, but we don't need to go there yet. You got to have the big test first, which is the pelvic floor assessment. Elizabeth says, I think there needs to be a different name for those whose issue is pelvic floor. Originally, IC referred to this to a problem with the lining of the bladder. Now it seems that people with that issue are not being recognized. Elizabeth, there is, and they just started using it literally a couple of months ago, maybe a year ago. It's called myofascial frequency urgency syndrome. That's the new name, myofascial frequency urgency syndrome. And I will build a website on that too. You know, names are challenging because we now have generations of doctors trained in the name interstitial cystitis. Many have been trained with old information. Well, we also have guidelines that with Social Security disability that mention interstitial cystitis. And so, even though most of the world is not using interstitial cystitis too much anymore, most of the world is calling this bladder pain syndrome. And in Europe, the only patients who get a diagnosis of IC are patients with Hunner's lesions. For everybody else, it's bladder pain syndrome. And we just had a call, a strong call here in the United States about 6 months ago to encourage us to stop using the name interstitial cystitis. And I agree with that. Everybody believes and agrees that this is the wrong name. This was a name that was used 120 years ago when they thought IC was a problem with the interstitial layer of the bladder, but now we know that's just not true. The challenge is it's going to take a lot of change to make that happen. It is. Oh man, I got a bug. I got a bug in my drink. All right, hold on. I got to go refill this because my mouth is getting a little dry. Give me a minute. Look at that, a little fruit fly. All right, I am back. Who knew? 10 years ago, if you'd asked me if I was going to be spending hours talking about bladder stuff online and that I could talk about it for hours, I would have said, no way. It's crazy. Wendy said, wish you could see a pic so everyone could see. Yeah, or wish you had one. Sandy said, I had a constipation push to poo, left side rectum anal fissure, tight pelvic floor can cause this form of constipation. Yeah. Yeah. Undoubtedly, you probably had tight pelvic floor muscles that were making it very, very hard for you to have a bowel movement. So you just pushed and pushed and pushed and pushed and pushed until you ended up with a fissure and you ended up stretching stuff. Joe says, so you don't have IC? Oh, my diagnosis of interstitial cystitis was 30 years ago. Today, if I were seeing a top tier doctor, my diagnosis would be myofascial pelvic pain syndrome combined with estrogen atrophy and widespread pain. John says, which muscles typically cause penile pain in men? John, it's so nice to see you, and I hope that you're doing well. I'm not sure, but I think it's elevators. You know who would know? Hold on a sec. If you go to pelvicpainrehab.com, Pelvic Pain Rehab is the website for the Pelvic Health and Rehabilitation Center, which I think that they're literally the best physical therapists in the country, if not in the world. And they have offices on the East Coast and the West Coast. But what they have that's just phenomenal is a blog. And their educational blog, I get new blogs every day. Their content is exceptional. I wish I could be as productive as they are. So like February 27th was a discussion of pudendal neuralgia versus cauda equina. The one before that is your pelvic floor wants you to breathe better. Here's why. Here's the one before that, better orgasms for everybody. It's another one, overcoming hysterectomy, prolapse repair, and returning to paddle boating. There's another one, clitoral adhesions, clarity on clitoral care. That's worth talking about. Their section for men, their blogs for men are exceptional. And so I would go here. Well, let me just see. Is there a search command here? Yeah, there is. Hold on. Because if anybody's written about it, it's them. Why do men develop penile pain? And here's another one. Penile pain, frequently asked questions and answers. Here, let's check this out. Um, 1 in 10 men will suffer from chronic pelvic pain syndrome at some point in their symptoms. Men can develop penile pain for a number of reasons. Number 1, excessive exercise. Number 2, aggressive force or frequency of masturbation. Number 3, persisting pain after disease, infection, or inflammation. Number 4, penile enhancement procedures. Symptoms would include urinary frequency, urgency burning, penile pain, perineal pain, post-ejaculatory pain, and erectile dysfunction. And these symptoms are exacerbated by sitting, exercise, ejaculation, urinating, and bowel movements. And spoiler alert, the majority of men with these symptoms do not have a prostate infection. Do you know the proper way? Okay, hold on. The most common symptoms of pelvic pain that we see in our male patients include penile pain, specifically pain at the tip of the penis. Other common findings include tight pelvic floor muscles. Okay, anyway. When men report a burning, shooting, stabbing pain in the shaft or the tip of the penis, that pain is typically due to an irritated nerve. More specifically, that nerve is a branch of the pudendal nerve. Here, you know what? I'll post this link here for you. And so it's that pudendal nerve that's being squeezed by tight muscles that is all likelihood driving a lot of that pain at the tip of the penis. And guys, listen, I will never forgive a support group on Facebook who kicked a man out by the group leader said men don't get IC. Baloney. Are you kidding? I have worked with so many men in my career who have these symptoms. It's just heartbreaking that men do not get the support that they deserve. And so I just want any men out there who might be watching this that I am here for you. I mean, listen, my first support group was filled with men. And at the end of the meeting, all the ladies would leave and all the men sat around with me. And what was amazing is most of them were medical professionals. I had a bunch of pharmacists in my group. And because I was trained as a pharmacologist, we all just sat around and just theorized about chemicals we might have been exposed to. But very early on, I saw that men really struggled to get the care they needed. So I'm here for any man who gives me a phone call. I really want to help. Joe says, what does it mean when there's visible shedding of the bladder wall? Is this likely due to chronic infection? I don't know. I can see it correlating with infection, but I can maybe see it correlating also with chemotherapy, where the chemicals of the chemo might be damaging the bladder wall. I can see it happening from drinking way too much Diet Coke or ketamine. I mean, clearly what it signals is we have a bladder wall in distress. Sandy said, after you push to poo, you get an achy pelvic floor and urge to pee. Is that tight pelvic floor? Yes, honey, it is. Laura says, how to deal with bladder leaks. Boy, Oh, well, so bladder leaking is often due to muscle weakness and muscle trauma. And so a visit to a pelvic floor physical therapist will tell us what we're dealing with. If your muscles are very weak, they're going to have you do strengthening exercises and Kegels. If your muscles are very tight, then they're going to have to look at it in a different way. Um, I have leaked more in the last since my surgery. I have, and it baffles me. I mean, like, I literally wear a mini pad every day right now, an organic cotton mini pad, which don't like wearing mini pads, but um, I don't necessarily understand the process of why that happens to me sometimes. The only thing I can tell you is that I think stress and inflammation have messed with my body massively since the surgery, double mastectomy. And I now have had moments, and because of that, I couldn't be fit. I wasn't able to do the workout. I still can't do some of the workouts I would normally have done. I have a lot of chest pain and pulling. And I think my muscles got very, very dysfunctional. And I have had moments where, um, two moments where it literally felt like my pelvic floor had locked down like a board. And there was nothing I just literally just tinkled a little bit, drop a little bit of urine coming out. And I'm like, what? Why did that just happen? And both times it was under periods of very, very intense stress, like before going to the emergency room. Oh, the joys of having a human body and the joys of getting older. If you're leaking all the time every day and you're leaking a lot of urine, you got to get to the doctor. They got to figure that out. That doesn't happen to me, but they need to figure that out. Sandy said, "All my issues are after I go to the bathroom bad, then the urge to pee starts. I don't like going to the bathroom, then pelvic achiness starts. My issue is IBS-C causing IC. Honey, underneath it all, it's the pelvic floor contributing to both. They're both caused by problems with muscles and nerves. You need to get your pelvic floor checked." Julie says, "Why does azo help? Because azo numbs the nerves in your bladder. That's all it does. It's a fake out. It takes the pain away for a little bit of time, but the pain always comes back. So it's a superficial numbing agent of the bladder wall. Usually recommended for people who have basic bladder irritation or UTI irritation. I will tell you that azo never touched my pain, never. But we know why, because I'm pelvic floor driven. Azo numbs the bladder wall. It doesn't do anything for the pelvic floor. So azo never had a chance of helping me. What helped me was a muscle relaxant like Flexeril. That's what tremendously helped my pelvic floor. V says, I have generalized anxiety and TMJ, so I feel like you tense muscles. You do tense muscles. And because the fact that you have anxiety means that you're in fight or flight, honey. And that's part of the widespread pain phenotype. So we now know this group well. I'm also in this group. And so when you're anxious and you're in fight or flight, what does your body do? It prepares you to run or flee. How does it do that? Well, the first muscle group it tightens is your pelvic floor. So when you're under stress, this is subconscious. You don't know what's happening, but your body subconsciously is preparing you to fight or flee for your life. And that involves tightening your pelvic floor. So there are some patients out there, and I was working with another patient this week, who grew up with a very violent alcoholic father, very violent, and uh, she had been scared for her entire life. This is all about how does a child's brain respond to trauma like that. Well, what happens is you kind of get hard coded to stay in fight or flight. And so, even though it happened in childhood, the challenge is you're now in your 40s or 50s and you're still anxious as hell. Why? That's your brain remembering the fight or flight, remembering what happened, and kind of basically being stuck there. And so, therapeutically, for patients with widespread pain anxiety disorder, we have to unstick you. You get unstuck. The whole point of that is now to get your brain out of fight or flight. And we do that with mind body medicine and CBT and a couple of other techniques. That I'm seeing two therapists right now, because I just had terrible trauma in my childhood, and then man, I had it locked down. You guys have seen me doing these meetings. I mean, I was good until my parents died last year. And just the trauma of losing my parents combined with cancer is just, and my anxiety is escalated again. And so, it's not as bad as it was 2 months ago, but I don't like living with anxiety. I don't like catastrophizing. And the funny thing is what do I catastrophize about earthquakes or fires. Like every day, once or twice a day, I'll go, "Ooh, is the big earthquake going to happen today?" I would like my brain to stop doing that. And so I'm seeing a trauma therapist, and I'm loving every minute of it. And I'm seeing a medical anxiety therapist through betterhelp.com online. And I'm really happy with that too. And I'm finding myself, the way I've described myself for the last year and a half is that, like, I'm a bear in a cave. I'm in the back of the cave. I've been hurt big time. And I'm looking out the entrance of the cave going, "Do not come into my cave. Leave me alone. I need to heal." Like that has been my state of mind, especially after the cancer surgery last summer. It's just like, leave me the F alone. And it was so bad. I didn't want to be touched. It's like, leave me alone. I was just so traumatized by it all. And that's normal. Yeah, I was traumatized. We've all been through big time trauma. It's recognizing when it starts messing with our ability to function that's the problem. And I'm very invested in doing that. And I'm working hard to get out of my cave. And so yesterday, for example, I left early at like 9. I went and walked a couple miles, and then I drove 20 miles up to my sister's house. And I hung up with her, and they were like, "Oh, it's nice to see you. It's a surprise." Look, I'm just practicing getting out of my cave. I don't want to be a cave woman anymore. Healing. Okay, hold on a sec here. So hold on. Julie said, "Is baclofen the same as Flexeril?" No. Baclofen is non-sedating. You can take baclofen during the day. You can drive with baclofen. It's fine. Flexeril, on the other hand, can be sedating. And so when I take Flexeril, I usually take it before I go to bed. Or if I'm traveling, but I'm not driving. Because my goal is just, I know that if I've got to get on a plane, it's the drive to the damn airport that's the problem. I'm riding at the airport, or the 2-hour drive to the airport or bus is like on my pelvic floor. And almost every time I've tried to do that in the last 30 years, I've arrived at the airport in tears and in pain because my pelvic floor is spasming. And so my new routine is I pre-medicate with Flexeril before I get on the bus. And I take a quarter of the lowest dose of Flexeril every 2 hours for the entire duration of the trip. I got a spot right there that hurts. Ow. Sandy said, when you get pelvic floor therapy, can you get a bladder infection from them sticking fingers in your vagina? Honey, they're gloved. They're wearing sterile gloves. And so usually, no, you don't get the infection. Um, so I really wouldn't worry about that too much. Pamela said, I'm true. See this, it's this, I have to do this because I have to work on this incision. So I'm sorry. I just, when it hurts, I have to rub it. Pamela says, I'm truly trying the diet for IC. Ramen noodles put me in a flare. Didn't realize it was so bad because I don't eat much, but I do have fight or flight a lot because of my parents fighting so much. I'm learning. Yeah, honey. And the thing with ramen noodles is it's got MSG in it. There's a lot of salt in it. There's a lot of acid in it, and it's got MSG, and MSG is brutal. Monosodium glutamate. So if you want to do ramen noodles, don't put the spice packet in. Like do the noodles, and then put a little butter on it. You know, maybe a little bit of cheese, something like that, but don't use the ramen seasoning because of the MSG level. It's probably too high. John said, my PT often works on the bulbospongiosis muscle. Good. I mean, John, do you feel any improvement after she does that? Anne says, is sea buckthorn good for vaginal atrophy? Yes. Sea buckthorn, where did I first heard about sea buckthorn maybe 10 years ago. And so sea buckthorn, I'm trying to remember what it is about it. Is it an anti-inflammatory effect? So sea buckthorn is a plant found throughout Europe and Asia. The leaves, flowers, seeds, and fruits are used as medicine. It contains vitamin A, B1, B2, B6, and C. People use sea buckthorn for burns, eczema, acne. You know, we use sea buckthorn topically, not swallowing it, but putting it in a gel. I mean, that's when I use it because I use vulva balm every day. So it's often used for burns, often used for eczema. Oh no, it's not used for eczema. It's used for burns. You can take it by mouth, they say. I'm going to sneeze. Hold on. Excuse me. It's allergy season. They say it's possibly safe for use orally for up to 90 days, but there's not enough information on it. Using it on topically is much more common. Might slow blood clotting when taken as medicine. So do your research on it. But so our allergies, you know, it's spring. Our trees are starting to bloom here in California. And when I woke up this morning, my nose was running. And then as I was walking this morning, it was very, very windy because we have thunderstorms coming in. And now I'm stuck in a sneezing, runny nose mode. Adele says, I found hydrolyzed guar gum brilliant for constipation. Couple teaspoons of water every morning. Okay. I do acacia fiber myself. If I'm starting to feel like I'm struggling with constipation, acacia fiber, which is a a soluble fiber that's very gentle on the bowel as compared to an insoluble fiber. Patients with IBS, patients with a very, very sensitive nervous system, don't do well with granola. We don't do well with psyllium. They're too rough and they irritate the nerves. We do better with soluble fibers, fibers that dissolve in water. And so a good example of that is acacia fiber, like we have in the IC Network shop. Heather's acacia fiber for IBS, which is what I use. Do I have it in here? Yeah, here you go. Heather's tummy fiber. Yeah, and it can be used for constipation and it can be used for diarrhea. It can be used for both because it's all about giving your bowel the structural support it needs for healthy bowel movements. But my go-to, to be quite honest, is green peas. Very first thing I'll do is I'll just microwave a package of frozen green peas and eat that. And I'm telling you, it works well. Oh, anything interesting happening? So, what else happened? So I did a drop-in meeting Friday on Facebook. That was fun. Friday night. What am I working on right now? I'm working on our flare guide. Our magazine, our latest magazine, the IC Optimist, went out. You should be getting it in mail if you haven't gotten it yet. It should be coming very, very soon. Getting more and more success stories with lactoferrin. Gotta say it. It's more and more patients are calling and saying, I had one patient call to say it turned off her urethral pain. And yet here on, hold on a sec, somebody on YouTube here, Katie said she'd started it, but she had diarrhea from it. Yeah, and so lactoferrin acts to kind of, it gives your body what it needs to fight infection. And so if you've got dysbiosis in your bowel and you get the lactoferrin is going to boost your body to try to fight some of that, and that's going to potentially trigger bloating or diarrhea. I take it, and I haven't had bloating or diarrhea, but it's possible. Whoops, wrong mouse. B says, can we have chia and flaxseed? And Danielle said it's helping her too. Danielle's doing well with the lactoferrin too. I heard that they're talking about it a lot over on one of the other IC forums, but they're recommending some American brands, and I really disagree with that right now because of bird flu. Our domestic dairy industry is heavily impacted by bird flu right now. And I am just not comfortable recommending any lactoferrin from the United States. I just don't think we know enough right now. And so the lactoferrin that you can get in the IC Network shop comes from Australia, where there's no bird flu. Kathy says she received her magazine on Friday and the information has been so helpful. Kathy, thank you, honey. Thank you. I mean, I'm trying. Our theme for our spring issue is going to be about the biome and myofascial frequency urgency syndrome. I mean, like, I'm already writing it in my brain. I'm not going to start physically writing it for another month. I got too much other stuff to do. Pamela says, does baking soda neutralize acid? Does it help it out? Does it help to put it in acidic food? You have to be very careful with baking soda, honey, because it's salt. It's sodium hydroxide. And it will raise your blood pressure. And so, especially if you're an older woman, if you're over the age of 40, one of the things that happens with perimenopause and menopause is our female body, as we get a little bit older, starts to lose its ability to metabolize salt correctly. And so I think the statistics, what's the statistics is like over 50% of older women have high blood pressure. I do. And I'm shocked by that. I do not like having high blood pressure. It's not, I mean, my blood pressure, if I'm not walking, I'm stuck at like 135 to 140 by 75 to 80. And 10 years ago, that was considered normal. Now they want you down in the 120s. I just can't get there. I can only get there with one medication. And the problem is the medication turns my thyroid off, amlodipine. So finally, a doctor, basically said, "You're just a 140 over 90 girl. You're healthy. You're exercising." The lowest it's been is 110 over